So please go ahead.
Thank you.
And here's a laser.
That's the laser, okay.
Yeah, but doesn't advance the slides.
Okay, okay. Good morning. I'd like to thank Drs. Moglexi and Chung for inviting me to this really exciting symposium. I'm delighted to be here, and it's nice for me to just to drive across the bridge to come here. So the topic that I've been asked to address today is delirium in hospitalized patients, the role of sleep disruption, opioids, and pain. Can you hear me from the back of the room? Okay, there's no echo. Good, thank you. So disclosure, almost all my research has been funded by the National Institutes of Health. However, there is a pilot study that I will discuss with you today that was funded by Masimo Corporation, and that collaboration ended about late 2011. And also another disclosure is that I should tell you that I'm really relatively new to sleep medicine research, and my sort of interest in sleep really stemmed from my interest in outcomes research in the older surgical patients. And through our work in learning about postoperative delirium and cognitive decline, we found a connection with sleep disruption. So I think perhaps we can explore the role of both, perhaps, and the interrelationship. So before I begin, I just want to give you a few definitions just to set the stage right. First of all, what is postoperative delirium? It's really an acute confusional state with alterations in attention and consciousness. And it's thought to be reversible, so usually don't have persistent delirium, although sometimes that does occur. And then you've heard this term a lot, especially in the anesthesia world, POCD, which stands for postoperative cognitive dysfunction or decline. It's really a decline in a variety of neuropsychological domains, such as your memory, executive functioning, and speed of processing. And then the last term, which we all know, which is dementia, and it's really a chronic, insidious decline in cognition. And Alzheimer's, we know, is the most common form of dementia. And a lot of the patients we see after surgery really have delirium superimposed on dementia, which is actually quite tricky. So how often do we see postoperative delirium? It occurs after a variety of surgery, and I listed here primarily after non-cardiac surgery. And the range goes from, let's see if I can get this right, about 10% to as high as 50%. And certainly very common after hip fracture and also major aortic surgery. And the one highlighted in blue is our local experience. In about over 300 patients, we found an incidence of 46% in the first day or two after surgery. I think we found a very high rate here because we had been studying a really older cohort of patients. So it's definitely depending on the patient population and the setting. And the delirium in all these studies are measured by the criteria of DSM-4. Now, so you might want to ask, you know, in your practice, how often do you see delirium and how does it compare with other sort of adverse outcomes after surgery? Plotted here, I have for you myocardial infarction, which we all know and wanted to avoid. It's about 5% overall in unselected patients. And delirium, if you average all the studies, is 25%. So it's 5-fold more common than postoperative myocardial infarction. So clearly it's an important adverse event that we should think about as perioperative physician. Delirium is thought to be a geriatric syndrome. That is, it's not just like myocardial infarction, it's the heart. It's really multiple things at play. And Shen Inoue really is the sort of the mother for delirium. She published a paper in JAMA back in 1996 that described that delirium is really a result of the interaction between patient factors we call vulnerability and extrinsic factors, sometimes called precipitating factors. So let me illustrate to you what it means in this slide. In this study, the patients were medical patients hospitalized for acute illness. The baseline risks identified by this study included visual impairment, cognitive impairment as measured by the Mini-Mental State Examination, Apache score, so severity of illness, and BUN creatinine ratio. In the study, the precipitating factors were patients who were restrained, they were giving 3 or new medications, poor nutrition, having an indwelling bladder catheter, and any iatrogenic event. So the interaction goes like this. The more baseline risk factor, superimposed by more precipitating factors, increase the rate of delirium. So this is a pretty, I think, useful conceptual model to think of delirium. The next question is, okay, so now we know that it's frequent. Why is it important? We know that from studies after studies that if someone developed post-operative delirium, it prolongs the hospital stay by 1 to even a couple of days. So clearly resources. Furthermore, there's very strong data to suggest that functional status is decreased after discharge. There's also cognitive decline after discharge. Patients are more likely to be institutionalized, such as placed to a nursing home or skilled facility. And there's also very strong data to suggest that there's increased long-term mortality. So in this lecture, I just want to focus on really sort of 2 or 3 entities because it's a vast topic. I want to talk about risk factors that might be potentially modifiable. So I think I would include them as the precipitating risk factor. The second topic would be post-operative pain status and post-operative pain management. So sleep disturbance, particularly changes in sleep patterns and architecture, are very commonly observed in older subjects. And by the way, delirium risk is increased as one ages, so that's certainly one of the risk factors. What you've seen in multiple studies is that in older subjects, there's a reduced sleep efficiency. That is the ratio of time asleep to the time in bed. That's decreased. There's also sleep fragmentation with aging, decreased quality of sleep, and also decrease in the slow wave sleep that's thought to be restorative by almost 2% per decade. The relationship of this sleep disturbance and surgical patient had been studied by a few investigators. And this is one example that was published in the surgical endoscopy because one of the patient population was laparoscopic cholecystectomy, which is the patient highlighted in the triangle. And then the solid, I guess a square, these patients who undergo major abdominal surgery. So what these investigators did was that they measured sleep using motor activity. And it's a wristwatch that many of you know that measured really acceleration. So it shows motion. And as you can see on this slide, the nighttime sleep time is plotted on the y-axis. In the laparoscopic group, they were roughly unchanged in terms of the nighttime sleep. But in the open abdominal surgical group, there was a decrease in sleep time from post-op day 1 all the way down to post-op day 4. Even elective outpatient surgery, it has been shown that there was sleep disruption. A second study here was 127 patients, including a control group, which was useful in this study. This was all outpatient surgery. Sleep was measured again using actigraphy. An additional measure in the study was anxiety score, pain, energy level, and also a sleep history, so self-reported sleep history. So in this study, approximately 23% of the patients experienced clinically significant sleep impairment after surgery. And more difficult recovery, they have increased pain and low energy level. In contrast, the control group, which was community dwelling control group, only reported about 3% of the time they had problem of sleep. So a difference, pretty marked difference. And then a moderate proportion, they concluded that our patients experience post-operative sleep problems even after a pretty routine outpatient surgery. So we, our group, undertook a pilot study, and Susanna Vacas, who is one of the postdoc fellow in Dr. May's lab, who's an anesthesiologist, played a pivotal role in helping to move the study forward. We were interested to look at the sleep disruption in ICU patients. And ICU patients also had a very high rate of ICU delirium. And we knew that sleep is probably not that, sleep disturbance is probably a very frequent phenomenon. So in this study, we actually wanted to do a pilot study to see if there's a simple way to measure sleep. Polysomnography is the gold standard. And we want to have the ability to look at, sleep waveforms. So we used the Masimo SedLine, which is a Foley EEG, which is relatively non-invasive and placed on these patients. We also simultaneously measured delirium using the CAM ICU. So we recorded these sleep waves and we scored them using the 2007 American Academy of Sleep Medicine guidelines. So this is a typical hypnogram. I know that it may be very small for those in the back, but this is the time. So 5 p.m., this is 11 p.m. So this will be from here, the right half of the strip would be considered as nighttime. And here would be wakefulness. W, R is REM sleep, N1 non-REM sleep, N2 non-REM, and N3. So these are the slower waves, deeper sleep. So as you can see, there is frequent oscillation between sleep and awake during this period when one should be deeply asleep. And you don't see that. And there's also a marked absence of REM sleep in this ICU patient. What we found was that in these 24 patients, we found that the sleep was distributed throughout the day and night. So they're not really concentrating in the night as we think. There's an absence of REM sleep, as I talked about, and also absence of a normal sleep cycle, where individual transition from lighter to deep sleep and then alternating between non-REM and REM, and that's not really visible. And the sleep only, occurs in approximately 90-minute cycles. So every 90-minute cycle, they cycle. So they're really frequently in this sort of twilight zone, if you will. When we look at the actual amount of sleep, they actually seem to have achieved a sufficient quantity, like average of about 8.5 hours over a course of a 24-hour period of monitoring time. But there were definitely signs indicative of poor sleep quality. So there's a reduced time spent in REM sleep, only 3% of the total time sleep when 20% is normal. Stage 3, which is the slower wave, is only 0.1% of the total sleep time, where 5% is normal for this age group. And more importantly, I think is really there's a very high arousal rate, 23 arousals per hour. That's pretty remarkable. And then the poor sleep efficiency of 42% when you expect 80% in this age group. So in contrast, this is a hypnogram for a patient who went to a sleep lab for a diagnosis of sleep apnea. And this patient also simultaneously have PSG, polysomnography. So similar sort of display. As you can see, there's definitely more characteristic of normal sleep architecture. There's a descent from wake down to slower sleep, and then there's also presence of REM sleep. So you can see there's a big difference between this patient in a sleep lab and the one that I showed you from the ICU. Recently, we also undertook another pilot study, and that is using the wristwatch actigraphy to measure sleep in non-cardiac surgical patients. And this is a very small study, it's unpublished yet, in about 50 patients. And so in this study, we also simultaneously measured the occurrence of post-operative delirium. And so this CAM positive is the group with delirium, and CAM negative is the group without delirium. And we found that in the delirious patient, the sleep time is significantly lower. Wake time is significantly higher or longer. The sleep percent is lower, wake percent is higher, and the number of awakenings is trended to be higher, and also mean awakening. So this is consistent with the thought that really in patients with delirium, there's really a disturb in the sleep architecture compared to those who have no delirium. And so we're currently continuing this work. So you might want to ask the question, well, why do hospitalized patients not sleep well? We've heard about really 2 wonderful lectures on the role of opioids. I think in addition to opioids, there are other factors at play in the hospital, such as noise. And how often do you go to a hospital ward, even late at night is really noisy. Nursing giving report, physician talking to each other, vacuum cleaner, machines. So there's ambient light also. A lot of hospitals have ambient light throughout the day. Frequent measurement of vital signs, especially the sick patients. There's medication administration in a very odd hour of the day or night. Performance of medical procedures, particularly in the ICU, and tests. And also really sedative and analgesic agents, which have been shown to potently suppress low-wave sleep. And then in a surgical patient, post-operative pain and opioid, which we're going to talk about a little bit. And then the obvious is obviously sleep apnea, which will also affect sleep. But one of the important questions that I think remains to be answered is, does improvement of sleep-wake cycle leads to a decrease in delirium? That's a big question. Moving on to part 2. my group became interested in the role of pain and delirium because of a lot of the previous studies really focus on patient risk factor, and that's not something that's really modifiable. Whereas as anesthesiologists and perioperative physician, we manage the patient from before to after, and we frequently, help the surgeons with managing pain, with the acute pain service, for example, from the recovery room all the way to even to the floor. So we began to ask the questions, what are some of the factors that may be important that occur in the post-operative period that might contribute to the occurrence of post-operative delirium? So we began to ask the question, what about the role of pain? So in this slide here is shown the mean VAS score, visual analog scale, and on the y-axis is the preoperative period, which is the first bars here, post-operative day 1 and day 2. And this was a study of a couple of hundred patients. The group that's developed delirium is highlighted in black, and the one without delirium is the one shaded in gray. So what we found was the pre-op pain levels, this is non-cardiac surgical patients, older patients, was no different between the group with and without delirium. Whereas in the group that had delirium, the average pain score was significantly higher for both day 1 and day 2 compared to those without delirium. So when we first looked at these results, the first obvious question was that perhaps delirious patient can't really manage the pain that well, because most of these patients had the patient-controlled analgesia, the PCA. So it is possible that they're just not pressing the button, and therefore they have more pain. That's one possible explanation. So we took a subset of patients who received the PCA and looked at the average dose of opioid use. And in our institution, hydromorphone dilaudid is the most commonly drug tagged to the PCA machine. And I apologize for the smallness of the print, but let me just run you through the slide. So in the first half of the slide, this is the no delirium on post-op day 1, and those with delirium post-op day 1. And this is the hydromorphone dose on day 1. So interestingly, the mean dose of hydromorphone was no different between the delirious and the non-delirious group. Similarly, on day 2, you can see the doses decreases appropriately, no difference between groups. Now moving to day 2 with delirium, again, there was really no difference. In fact, the group with delirium, in fact, using a mean dose of hydromorphone, a lot higher mean dose than the group without delirium. And so I think the narcotic use, it educate us and tell us that patients with delirium are actually probably using same amount, if not more, opioids, as if they're having more pain, they're using more IV opioid, but it's really kind of maxed out, and their pain level is still high. So let's put that thought aside, because we're going to come back to that. So the next step we did was to ask the questions, well, who really are at risk for delirium if pain and opioid use are a really important factor? So we first built a model to predict delirium, knowing that there's been previous prediction model in existence, but those were dated back over 10 years ago where the management is quite different. So in our model of 581 patients, these are patients 65 years of age or older undergoing non-cardiac surgery at UCSF, we found that there were 5 important risk factors that increases the risk of post-operative delirium. First one was being female, interestingly. Second risk factor was having a lower cognitive status as measured by a Fung version of the MMSE. The third factor was having a history of CNS disease, such as stroke and other CNS disease. And the fourth and fifth were more surgical related, having higher surgical risk level and undergoing spine and major joint arthroplasty. We then stratified the patient into low pre-op risk and high pre-op risk based on how many points they receive. The relative risk of developing post-op delirium was 2.3, so double the risk in the high-risk group versus the low-risk group. So this is useful in terms of stratifying. But more importantly, when we ask the question, does the preoperative risk level moderate the effect of post-operative pain and opioid, we found some pretty remarkable results. First of all, if one was in the low pre-op risk group, primarily based on preoperative risk stratification, they have low pain level post-op and using low opioid dose, their risk of post-op delirium is low. And I have to tell you, the way we stratify pain and opioid is using 5, VAS pain score of 5 as a cutoff, and opioid dose of 8 milligrams of hydromorphone equivalent as a cutoff. That's about the 75th percentile in our patient population. So to jump to the high-risk group, if you were having high pain level, high-dose opioid use, the risk of post-op delirium was high. So in fact, the next slide probably illustrated a little bit better visually. If you had low post-op pain level, low dose opioid use, low pre-op risk, your chance of post-op delirium is 20%. So still not small, but 20%. But look at what that rate is when you have high pain level, high opioid dose use, and high risk. That rate jumped to 72%. So it's almost a certainty that one developed post-operative delirium. Well, if opioid really plays such an important role, what about if you use an anesthetic technique that minimize the use of opioids, such as the opioid-sparing technique? In a subset of patient population, my collaborator, Dr. Kinjo, who's in the audience, an anesthesiologist and pain specialist, took a group of patients in our cohort study who had undergone total knee replacement and looked at which patient received PCA, that is opioid-based pain management after surgery, and those who received the femoral nerve block placed during surgery. And I can tell you our clinical practice at our institution changed. About 10 years ago, or maybe 15 years ago, we had used epidural, and that got really removed, as we all know, with the advent of low molecular weight heparin. So epidural is really out of the question, and so we were using a lot of PCA for management of pain after knee surgery. And then really about 10 years ago, we started to introduce peripheral nerve block in everyone. So this is a subset. And what we found was really remarkable. In the patients who developed delirium, in the PCA patients, about 60% developed post-op delirium in those who received PCA as the primary pain control after surgery, versus the group who received femoral nerve block, about 25% of them have delirium. And this was significantly different. Now, we did look at the amount of opioid used in this study, and they were not different between the two groups. And I can't really explain why. Perhaps in the early stage of learning how to do femoral nerve block, there's probably quite a bit higher failure rate. After all, we are a teaching institution. Unfortunately, we cannot really conduct this as a randomized trial because femoral nerve block has become sort of a standard of care at our institution now. But this is a pretty remarkable difference. So if you go back to the previous thought that I shared with you, that is high pain level, high opioid use was significantly increasing the risk of post-op delirium. The thought at the time I had was, what about if we really have an opioid-sparing technique? Would that really help with the reduction in opioid use and delirium? Now, we know that femoral nerve block is really only applicable to knee surgery. So I was really in search of a drug, if you will, that could be widely applied. So this was developed in the early 2000, mid-2000. And at that time, the thought of gabapentin came up. Gabapentin is a drug that's FDA approved for the treatment of partial epilepsy. And there have been a lot of studies up to that point that use gabapentin as an adjuvant, if you will, for management of pain. And studies after studies have shown that gabapentin reduces post-operative opioid use. However, the link between post-op opioid use and post-op cognitive outcomes had not been established. So we undertook a pilot study, 21 patients. Randomized them, double-blind. One half received placebo. The other group received gabapentin. And these were all patients undergoing spine surgery. And basically, gabapentin was given preoperatively, 900 milligrams PO on call to the OR. And then gabapentin was continued for 3 days afterwards, 300 TID. And the dose reduced, adjusting for renal clearance. At that point, all we wanted to show was it's safe and feasible to do that. So after 21 patients, we unblind and looked at the safety profile. And we found that the drug was well tolerated with no major side effects such as the oversedation, dizziness, nystagmus that you will see commonly with some of the report on gabapentin. But to our surprise, there was actually a significant difference in efficacy in that the patients who received gabapentin, none of them developed postoperative delirium. And the one that received placebo, 5 out of 11 or so developed delirium. So this was significantly different. And so we were quite energized, and we also looked at, the amount of opioid use. This is, again, hydromorphone equivalent. I know the number is small. So there is a trend for a lower dose of use of hydromorphone in the gabapentin-treated patients compared to the placebo-treated patient. So with this pilot study, we were quite energized, and we went ahead and wrote up a bigger study and received funding by the NIH. And so that provided the basis for this ongoing study, which is the exact method that we talked about. That is gabapentin pre-op, continue for the first 3 days. And then we also obviously measure delirium and cognitive function. So the hypothesis of the study is that rates of delirium and POCD can be reduced in those who are vulnerable to experiencing these outcomes through intensive pain management after surgery. So I can give you a brief study update. We have studied 670 patients, so we're actually very close to reaching our end date. It's been a really big study, extremely labor intensive, so we're hoping maybe end of the year will be done. We've gone through 2 rounds of safety analysis and looking at compliance of study medications. We're looking at sort of adverse event. This is really perhaps the only thing of note is the low, relatively adverse event. We included patients undergoing not just spine in the study, but hips and knee replacement. The delirium, interestingly, showed that overall delirium rate was about 24%. If you recall, our previous cohort was about 40%. But obviously, we're still blinded. So this is compared to a historical cohort of 363 patients, similar surgical characteristics, and again, is 25% versus 47%. So we don't know whether this is the effect of the drug, but overall, the delirium rate is reduced in both the placebo and gabapentin-treated patients. So to summarize, I think despite the prognostic significance established between sleep disruption, pain level, and opioid use and post-op delirium, there's really been a lacking of randomized control trial to establish causation and preventive strategies. I think sleep disruption and pain may be closely related, and then especially the treatment of pain may lead to better sleep. So I really think there's really a call for action at this point. We really need more hypothesis testing, randomized control trial, to see if we modify some of these risk factors, such as pain, opioid use may lead to better sleep, and therefore decrease in delirium in hospitalized patients. The final slide, I just want to acknowledge my collaborators, Dr. Laura Sands, who've been really a trusty colleague for over a decade, Sakura Kinjo, who's in the audience, Ken Kavinsky, a geriatrician at our institution, Joel Kramer, a neuropsychologist at our institution, and scores of really very excellent research assistants, and then the funding agencies. Thank you very much. I think I make up the time.
So now is a good time to take questions. Go ahead, Tom, please.
Right, so I think in the West Lilly paper that you cited, they basically found that new use or new administration of lorazepam was associated with an increased risk of ICU delirium. To date, there's been no randomized trial to look at patients, either ICU patients, I should say post-op patients with or without benzodiazepine, and whether that decreased the rate of post-operative delirium. I want to concentrate on post-operative. Knowing that there are obviously other studies that look at sedation in the ICU, the Precedex, propofol, midazolam. So a frequent question that my colleagues asked me was that, should we skip that pre-op dose of midazolam, in someone who's at risk of post-operative delirium? I think the clinical answer is that if there is not a need, you don't have to give it. You would only treat it if someone is anxious. But there's really been not in any sort of evidence-based manner to suggest one way or another. In the medical patients, it's well known that patients who are on chronic benzodiazepines have an increased risk of in-hospital delirium. Now, whether that's due to withdrawal once they get admitted is not clear. So there's a lot more work to be done on, the benzodiazepines in surgical patients. Yes.
Quick question. Did anybody look at the pre-operation delirium? For example, the one patient had 82 years old lady. We calculated the dose. Before we deliver the dose with 25 microgram cranial, she definitely meet the criteria for the delirium.
Mm-hmm.
So after surgery, still not serious for 8 days for delirium.
Yeah. So okay, sorry. I think the gentleman asked the question that what about preoperative delirium, right? He was placing an epidural and he gave like 25 mics of fentanyl. The patient became really delirious. So I can tell you in the hip fracture patients, that question was actually addressed. And I forgot the author's name, but they actually looked at preoperative delirium. And in hip fracture patients, there's a moderate proportion of patients with preoperative delirium. About 20% of patients were actually delirious before surgery. But more importantly, I think with your patient, is it the fentanyl that caused the disorientation or agitation? Or is it patient risk factor? I suspect it's both. I suspect that if you actually have the time to evaluate this patient probably had preoperative cognitive impairment that either is not known or not documented. Because unless someone has dementia written all over the chart, most of the time we don't know, especially in a very brief pre-op visit. So would the fentanyl cause the agitation? Possible. I mean, opioid, even in volunteer, has been known to induce cognitive changes. So clearly opioid has some role. But opioid is also beneficial, as we know, in treatment of pain. So we can't completely take it out totally. But in a situation where you don't need the opioids, perhaps it's worthwhile reducing it or eliminating it if there's a possibility of doing it. So clearly, I'm not telling you all to not give opioid because that's not possible. But I think that if there's technique of opioid sparing, I think we should consider giving some of the data that we've seen.
There was a question in the back.
Yes.
Congratulations on a really nice body of work.
Thank you.
I'm just curious, from a mechanistic standpoint, one of the positive mechanisms for why dextromethorphan may be more effective is because it acts on a non-GABA positive rationale.
I'm sorry, so you're asking what is the mechanism of gabapentin? Yeah, I mean, I think that I would not state that gabapentin reduced delirium because we only had a pilot study of 21 patients. So we really have to wait our trial to be properly finished, conducted, and unblinded to say that, to show that. So I think what's known is that gabapentin is opioid reducing. So it is used as a pain adjuvant. The mechanism is really unclear. If you look at the literature, it's really not clear. Interestingly, at our institution, even they kind of jumped the gun before we went and finished our study. They have even adopted and embraces multimodal therapy, of gabapentin, celecoxib, and what else? The third one, Sakura. Tylenol, acetaminophen. So actually, we have to modify our study and say, please let us continue until we finish. But we had to compromise. So sometimes clinical practice go before research finding, which is actually unusual. Usually it's the other way, right? I mean, you have research finding and people don't adopt it. So this one, somehow, at least our orthopedic service totally embraced that. They want to get rid of the PCA totally, which they're apparently very successful in doing. In the arthroplasty for knee, there's no PCA. They're not allowed unless they're excruciating pain. So I'm sorry that I think the short answer is that it's really not known, not clear, the mechanism of action.
Excellent. So we will reconvene back at, what time is it, Francis? We have to come back at 10:45. So we'll start on time. Thank you very much.
Please note that there is one of the exhibitors, they are not here, QRX, so you don't need to get signature on that one, and you can still win. So I would like to introduce our next debate. It's a pro-con debate, and it's by two great speakers here. And Andreas Tanzer is the assistant professor of anesthesia, Dartmouth College, Geisel School of Medicine. He is going to talk to us about should all post-op patients be monitored. Pro.
So, hello everybody. Can you hear me okay in the back? Yes? What about now? Not so good. Okay, so I have to stand over here. Okay, so thanks very much for the invitation to speak here. And as I just told Francis, I didn't even know this society existed. But sitting here in the morning and listening to the presentations, I think you have in common with many other smaller gatherings and meetings that the quality of the presentations and the knowledge of the people here is actually very impressive. And I enjoy these settings much more than the big ASA symposiums. I'm supposed to talk about if all postoperative monitoring patients should be monitored pro. I'm actually not going to fight. I'm just going to present on what we do and what we have done over the last 7 or 8 years. And you can look at it and you can see if you like it or not. I'm not trying to convince anybody. Quality improvement efforts of this sort are difficult to transplant to other places. We all are in very complex medical systems, and we're trying to achieve the same things by different means. This is just what we have done. This has worked for us, and I'll show you what it actually is that we have done. I've not received any compensation, I'm already walking away, from any company. I will use a product name here that is Patient Safety Net. It's made by Masimo. I've never received any funding from that company. I've never received any travel compensation or anything of that sort from any industry sponsor. I did have a grant from the APSF to study respiratory rate monitoring, and I'm going to talk about that at the very end of my talk because of where we are here. I wanted to talk a little bit about respiratory rate and its relationship to desaturations in an inpatient postoperative settings. I have some salary support from other things that are related to sepsis, and I have institutional support to look at inpatient deterioration. The work I'm presenting is the work of a huge team of people, my physician and engineering coworkers, nurses, people from the administration, from IT, my institutions, and all the software used for our work. And my presentation as well is freely available, and you can ask me about that if you want to. Just to talk about the setting a little bit, let me try to get this thing off at the bottom here. Sorry about that. I think we better go back. Okay, so this is DHMC, Dartmouth Hitchcock Medical Center. It's in New Hampshire. We have about 20,000 inpatient discharges a year, 90,000 inpatient days, and a third of those days are actually in units of escalated care, intermediate care units, or ICU days. So this is the underlying problem that we were faced with when we looked into the problem of inpatient deterioration in around 2005, 2006. There are twofold problems. One is that if you look back at deterioration, inpatient deterioration analysis, is that we have miserably failed to accurately predict on who is going to have an adverse event. And if you look at the rapid response literature or anything else that's out there, if you ask patients, even in the aftermath of an adverse event, which of these patients should have had special monitoring, like oxygen saturation monitoring, in the aftermath, knowing that there was an adverse event, people agreed on exactly 50% of patients. It was a coin toss. We didn't know. Okay? We cannot predict. I think that's a very humble acknowledgement. The idea that we can identify patients at risk put them in a room with a pulse oximeter and set that to do 93 somewhere is a flawed concept from the very beginning. The other one is that if you look at that very same literature, that there's a time frame of about 6 to 8 hours in which you see increasing physiologic instability, leading ultimately to death. Historically, we intervened somewhere here when the patient arrested with a co-team. And then since the mid-'80s or late '80s, rapid response teams were introduced that bypassed the hierarchical cascade of activating somebody by cutting out mostly the physicians, going from nurse to the rapid response team that would intervene here. Problem with rapid response teams is that their afferent loop, once they are activated, they do a great job. Problem is they don't know when to show up because they're relying on early warning scores or vital signs that are being taken every 6 hours. Furthermore, these vital signs that make up these scores are known to be inaccurate, right? All respiratory rates are 12 or 16. Blood pressures are totally inaccurate. And even oxygen saturation measurements are inaccurate. And we have a paper coming out in Anesthesia and Analgesia in the next few editions that demonstrates that oxygen saturation, as written down by nurses, are inaccurate for patients. And so basically what we did is, very brief preview, took patients who had average oxygen saturation of less than 90 over a 15-minute period, and then correlated that by an automated sampling system, and then correlated that with what the nurse wrote down in the chart. And on average, the number written down in the chart was 6.8 percentage points higher than the automated sampling. So we had a patient with oxygen saturation of 88 on average over 15 minutes. This is not just dips. This is the average oxygen saturation on the floor. Nurse walks in the room, writes down 94, 95. I'm not blaming them. You know, look at our anesthesia records, pre-electronic anesthesia records, you know. So this all led us to then realize that the only way on how we can address that problem would be to monitor everybody all the time. And so back then, I'm now somewhere in 2007 or so, we started to introduce routine pulse oximetry monitoring on every single patient on an orthopedic floor. This was originally in a 36-bed unit. And what we have seen, and this is a control chart, 12 months of data before, 12 months of data after. These are rescue events per 1,000 patient days per month. Being relatively high, having outliers here, to a more controlled process with much less events. And this is hard stuff, okay? Because this is just an example of one single patient. This is epoch time, which is what you get when you work with engineers. So these are seconds, Unix time. This is overall 6 hours. In red, you see heart rate, and in blue, you see pulse oximetry data. And what we see on many, many inpatients is repetitive desaturations, going down multiple times to 80. And then stress increases somehow, and here is a respiratory event. This is data collected in 1-second intervals over 6 hours. The problem is, for this one patient who then here had an adverse event, I have another 50 or 100 who do this every night, and then they go home 2.5 days after, and nothing bad happens. That's just the way it is. So it's not an easy problem to address with monitoring. This is where we are now, and this is data from DHMC code data over a few months of this year. And we rarely have respiratory codes by now anymore. They're almost entirely eliminated. When they happen, they mostly happen on patients who weren't monitored at the time. Now that we've reduced this, which in most institutions is somewhere between 40 and 70%, other stuff pops up. And we are researching this very intensely right now, what's going on with these patients. So the system we are using basically is a pulse oximetry network. They are bedside pulse oximeters that wirelessly
transfer the signal for heart rate and pulse oximetry to a central workstation that the nurse looks at. The system has the capability to alert nurses via a paging system if certain preset alarm thresholds are being crossed. Okay? We don't have anything like community enunciation. In our orthopedic unit where we started, one nurse takes care of 5 patients. If one of these 5 patients crosses certain preset threshold, that page goes out to that particular nurse, but not to everybody else. If the nurse does not respond to it in 30 seconds in the room, that alarm gets escalated to a buddy nurse. And that is the system as it's commercially available. So this central workstation stores the data for 72 hours, then it's overwritten. So we wrote some scripts to dump all this data on a research server that is owned by our institution, and we have now 50,000 patient days with physiologic data sampled in 1-second intervals available to us. With a boatload of data points, we can only run this through mainframes by now. It is by far and away the largest physiologic database in existence. These are the settings we used. And I want to remind you that this is totally different than one you do maybe for condition monitoring for certain individual patients that you perceive to be at risk. We are now in our institution monitoring every patient in general care units all the time, around the clock, except for OB and the ED, which are the 2 remaining units. We are also in pediatrics now, which is a totally different set of problems. But if you monitor everybody all the time, alarm control becomes the predominant problem, right? You have to reduce and address the alarm burden. And prior to using this system, we had a different system that we installed on pediatrics. We didn't have the experience. We didn't know how to control it. The alarms went off all the time. The nurses paid no attention to it. They didn't want to put the patients on the monitors anymore because it was a disincentive because false alarms were going off all the time. So the precondition to make this work was clearly to address the alarm problem. And the idea was, basically, we went to the nurses and said, well, how many alarms do you think you can tolerate? They were like, well, we think we can tolerate 1 alarm per patient per shift. I said, okay, we look at all our data, and we try to set the alarm so that it doesn't alarm more often than that. Okay? Realizing that setting the sets at 80, we may miss some patients who have really rapid declines, and we may not get to them in time. But our starting point was that we had patients dying in their beds under our care, and we didn't even know about it. This wasn't an approach to save everybody all of a sudden. This was an approach to make the problem significantly better than what it was. It was an airbag. The alarm is delayed by 15 seconds at the bedside, and then another 15 seconds until it goes out to the nurse and alerts her or him that the patient is crossing these thresholds. Now, there are patients with different physiology, so we have these standard settings. We allow the nurses, without any physician intervention, to adjust these up and down by 10%. And then there's physician-ordered adjustments for these going up and down. All right, this is just some data that comes out of our work group that looks at the comparison of average heart rates between medicine and surgery patients. I know I'm talking about post-operative patients. But based on these data, and oxygen saturation, we rolled this out, and because of the similarity of the distribution, we're monitoring everybody with these very same settings in the hospital, which makes the whole system more resilient. So this is our initial study that was published, I think, in 2010. And the way we studied it is by just using a before and after study design, using 2 surgical control units as concurrent controls. And as you know, the premise was that if we alert really early, we expected 2 things to happen. We expected that our rescue events would be going down, right? Because the nurses would be alert early on. We were hoping to just reduce the number of rescues right up front. And we also were looking at bad outcomes downstream, and because we don't have enough depth to have statistical power for that, we used ICU transfers. So our rescue events declined by 65%. These are box plots, sorry, 5 to 95%, 25 to 75%. Median dots are outliers. So while the other units didn't have any statistically significant change, on the unit, this is a 36-bed orthopedic unit with basically arthroplasties, overweight population, despite a very active regional anesthesia program with Brian Seitz, still use of opioids. Rescue events went down by 65%. Patients are relatively sick, acutely ill. Our average stay for total knee arthroplasties is now 2.1 days, so we don't keep them very long. This is a look at ICU transfers. This is for the original 36-bed orthopedic unit. They decreased by 45%. So in numbers, that actually meant that for the 12-month we looked at it before and the 12-month after, we generated 160 days in the ICU less in the after period just from that one single unit alone. So then subsequently, we expanded the system here originally from the orthopedic unit. You see rescue events before and after to the general surgical units and to the vascular thoracic units, and basically saw the same effects. How am I doing with time? I have an hour, right? 2 minutes? 5 minutes, oh, okay. All right, so early recognition doesn't matter. As I told you, I work on sepsis. So each hour of identifying earlier reduced mortality by 8%. So early is good. And so I told you initially that these 6 to 8 hours that you have before, what does it actually look in oxygen saturation? So if you look at the standard deviation, the fluctuation of oxygen saturation prior to adverse events, this is the control group. And these are patients who had rescue events. As you get closer to the event, the fluctuation actually increases, right? There's more bouncing up and down. It's not the average. The average is the same. The average doesn't matter at all. The median doesn't matter. There is more bouncing here. So we're trying to develop algorithms that show on can you predict these events. And so our goal was to predict events 30 minutes prior to them happening, enough time for intervention, and using a bunch of different techniques to predict them. And for respiratory events, right now, if you just look at the 30-minute subset, we are at about 80 and 80 for sensitivity and specificity. We are not better than that yet, but we're using machine learning algorithms with more data to make these systems smarter. Respiratory rate, I have 3 minutes or so. So recently we have added acoustic-based respiratory rate monitoring to this because there was this notion out there that bradypnea, low respiratory rates, are responsible for a lot of desaturations and adverse respiratory events. So these are 4,500 patient days with monitoring respiratory rate around the clock. This is a normal distribution you see in a post-operative population. It's never been done before. And interesting is there's no spikes at 12 and 16 and 20. The other thing is that you see that was surprising to us is this tail here, okay, of patients breathing really fast, 30 and above, 40 and above, unanticipated by us. And this year, almost nothing. This is the correlation of respiratory rate and oxygen saturation. And if you imagine this line here of SATs of 90, and you look at the respiratory rate here, low respiratory rates not really associated with low oxygen saturation state. Many of the fast rates not associated with low oxygenation states, okay? Patients desat with normal respiratory rates, basically, that's what we have found. And so then we say, like, okay, what about this notion that patients on oxygen are at such a great risk? Because, you know, in some institutions, patients are at risk for respiratory problems who are on oxygen go to intermediate K units. They are not even kept on general K units. So we're going to have a look at that. Red patients on oxygen, blue patients on room air. This is just describing the population of all oxygen saturation numbers and of all respiratory rates. All right, so first question was, well, patients who are on oxygen, who are on blue, when they drop their sats during their desaturation events, do they drop deeper and do they stay down longer, or does it happen faster? So these are saturation drops of 8%, 10%, 12%, occurring over 1, 2, 3, and 10 minutes. And you see here that overall in blue, relatively more drop a little bit deeper, 12% versus 8% for the room air group. And it happens a little bit faster. There's more bigger red bars there. But they also start out 3 to 4 percentage points higher on average because they're on oxygen. They actually end up at about the same level. All right, so the key question is then, well, what does respiratory rate do? When you drop your oxygen saturation by 8, 10, or 12%, what happens to it? And the answer is absolutely nothing, okay? There's no response. It's not a trigger. Nothing happens. This is the slope of change of respiratory rate during desaturations of patients on room air and oxygen. And it's all around 0. It's a normal distribution around 0. So during the desaturation event, when your sats go down 8, 10, or 12%, the respiratory rate during these events does not change. What about before? Maybe the sats go down. It's a delayed effect, as we all know, because actually the decline happens before the desaturation. So this looks at the 3 minutes before your sats actually start to drop. No difference. No difference on oxygen, no difference on room air. Doesn't change. What about a response? What about once you have dropped your sats by these 8, 10, or 12 percentage points? Does your respiratory rate pick up? Does it change? Does it do anything? No change at all. So this is the most recent work we have done on this. I think my time is almost over. So I told you that adverse events are preceded by a time of deterioration that ought to allow an intervention, that we haven't been able to predict on who is going to have an intervention, that the surveillance technology that we have right now is already pretty mature, that we may have a chance to predict with enough time on who's going to have a bad event, and that more variables may be helpful or not. It's not that easy to tell. Overall, our hospital has seen a sustained reduction in ICU transfers and rescue events. We almost have no respiratory codes anymore. We are now at a state doing this for 6 years where patients have to sign waivers if they don't want to be continually monitored. And we have stripped the privileges of individual physicians to write orders that they don't want their patients monitored. It's institutional policy. And so if they want a patient not monitored for whatever reason, they will have to talk to us first before they can write that order. So overall, we have found it prevents adverse events. It's a great data collection tool to look into problem. It does facilitate early intervention based on prediction. And you can all do this in a virtual model because we're collecting all this data. So whatever we can do now, I have such a basically huge virtual patient world that I can make changes in that environment before I actually roll it out into real-time patient environments. Thank you very much. And there are some papers that I quoted and that have to do with this talk. Thank you.
By Dr. Krishna Ramahandran. He's associate professor at University of Michigan.